Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain, because here, you are both patient and physician.
Hello, everyone, and welcome to The Patient Physician. I'm your host, Paul Smith.
And I am your co-host, Chris Fulbright, and we're excited to welcome Donna Lee McBride onto the show.
Hi.
Yes, thanks for joining us, Donna, and thanks for making time to be here today. You actually have a pretty full calendar outside of your full-time gig, plus your side work and comedian and raising money and being a mother. So we appreciate your time. Before we dive in, let's set the stage for the conversation and just high level, we'll talk about your career, what you're doing now, and then you can explore and tell us a little bit more.
Sure.
Donna is the Director of Business Development at NAU Urology Specialists and is responsible for the growth of the practice and for filling the provider schedules through marketing, community outreach, public relations. Her role also encompasses the health of the practice by helping the management team to keep morale high and staff motivated and doing their best, which is always very, very important. She's also the co-host of the Armor Men's Health podcast and one hell of a funny comedian.
Aw. Thank you. Thanks for having me. I'm so honored to be part of your podcast. It's so professional compared to ours.
Well, Christy's here. That we're doing something right, I guess, or maybe it's too professional. But
well, you have to remember, she is a professional comedian, so any of those could either be meant as funny or truth. We just have to figure this out as we go along.
That's right. I could be lying.
That's right. She's going to use this somewhere. So tell us a little bit about how you got to the role that you're doing now, and where I really want to take this, and I think where your expertise lies is in helping private practitioners. And so part of our audience, we see a very, very few, and we'll go there, that actually go out and explore private practice anymore. But tell us a little bit about your story and even what you're working on now.
Sure. Well, I have a really funny patient-physician story to start off with, if I can go into that. When I was in college, I knew I wanted to be a drug rep, and I worked at a doctor's office my entire career in college. It was Dr. Wallace's office in San Marcos at Texas State University. And
get him, cats.
Yeah, exactly. He was the best primary care physician, so sweet, so patient, so kind, super ethical, amazing person to work for. And he specialized in primary care, but he also specialized in orthopedics and head trauma. So he's a very serious man, and that's where I think I learned, what an ethical physician is and who I would want to work for if I worked in a medical office. And he was just outstanding for the 4 years that I worked for him. But very professional, very kind, never joked around. It was a very serious setting, as you can imagine, me in college being serious, but it happened. I was his medical transcriptionist, and I was a whiz. I mean, before we had AI and all the stuff, right? Back in college, I was typing 100 words a minute with absolute positive perfection. Like, I never made mistakes. And he just loved me as a college kid employee who did all of his transcriptions. Anyway, one day he came to me and he said, I need to talk to you. Can you come to my office? And I was like, oh my God, am I in trouble? So I sat in his office. It was the first time I'd been called into a boss's office, and I was terrified. Even though I knew I was doing a good job, I showed up on time. I was a stellar employee in college. And he said to me, and he's, like I said, he's a super patient, kind, professional man. He said, Donna, you've been typing everything wonderfully. And I said, okay, why am I here? Like, what, did something happen? And he said, well, when I talk into the microphone, I have been saying the patient presents with pussy-like lesions. And I was like, okay, what are we doing? Like, what are we talking about? And he said, pussy's not a word. And I went, what are you saying? And he said, spell it out in your head. But he was too professional to tell me to say it or spell it. And then I really realized I had been typing the patient presents with pussy-like lesions. Anyway, I hope he bleeped that out. But that was going on for 4 years, and he was hysterical. But he was like the epitome of patient physician. So I thought about him when I thought about this podcast. So I wish that all physicians could be as patient as Dr. Wallace.
Now, how long had you been typing that up before he chose to?
It was like 3.5 years. It was almost before I graduated.
Didn't you get suspicious after a while that so many people came in with the same situation to see an orthopedist and not, OB-GYN?
Yeah, that's a weird head trauma, Donna. Strange head trauma.
He was also care though, in urgent care. But I remember thinking, oh, good Lord, the people reviewing his records were probably stunned. But anyway, I was going to kick out of that story. But anyway, back to me. I started, like I said, in that doctor's office. Then I became a drug rep. I watched the drug reps coming and going. They're so professional and attractive and smart and kind. And they had lots of money. And I was like, I'm going to do that. So I got a job out of college. I went and got a sales position for 1 year because that's what I was told to do by drug reps. You have to have sales experience. And then I became a drug rep. And then my dad, who's a physician assistant out of the Air Force, one of the very first physician assistants in the country, that kind of parlayed me after I became a mom, stayed home as a mom for a while. I thought I have to get back into medicine. So I went into family care at Victory Medical Center here in South Austin. And I worked there for 7 years as marketing director, then clinic director, and always in a business development administrative kind of position. And then I joined my current group also 7 years ago, NAU Urology Specialists with Dr. Mystery, and handling all the back end things. And like you said, the growth of the company and the health and the wealth of the company. So I think in a nutshell, that sums it up.
So you ended up there. And I recall several years ago when we first met and he had brought you in, he and I were talking actually about his plans for expansion, because at that time he was just a sole practitioner in a single office. And I'll never forget, he said, I'm not really expanding and planning to try to get into other offices to grow my income. It's more of a defensive move because private practitioners are just having a difficulty competing with hospitals and bigger groups that are coming in and buying them up. So it was really more defensive to try to just maintain. Now, I don't know if that was the origin of it and where it's gone from there, but do you find that was the case then? Is it the case now? Are you still, as a private practice office, you've grown substantially in that time frame? Mm-hmm. What's the headwind there?
Well, I think, it's absolutely still true today. We not only are a small practice trying to survive, we're watching these solo practitioners fail, and it's not of their own doing. We blame the all evil insurance plan that we're reimbursed 8% less every year, and that for a small company and small practice, that's huge. I mean, we just can't survive on insurance alone. So a lot of models like ours are staying small and then having a really robust retail sales opportunity for the practice, instead of the patients going out and finding really cheap supplements that are probably have a ton of fillers. We have a really nice supplement line. We have a really nice retail line for what we do. We have pelvic floor physical therapy on site, and they have some retail items that they can share with the patients instead of the patients going to Amazon and trying to figure out what they need. We've got sex therapy on site, and those therapists as well, they have really nice retail options that make sense. But I'm kind of jumping all over, but we also align ourselves with offices with a similar mindset. So we only try to connect with other offices like oncologists and orthopedic guys or, endocrine specialists that are similar in size and at least privately owned. What we give our providers and staff is the option to have a say-so in the clinic. So we just hired 2 brand new urologists, and one of the 2 came to me and she said, I knew I wanted to join a small practice, independently owned practice, because all of my mentors in my residency and all of her programs said private equity is the devil. And you don't want to join a group that's owned by a private equity group. You want to join somebody who's a little smaller, or at least is privately owned and not nationally owned, because you'll have a say-so. So, right from day one, she's got a say-so in the practice and what happens to finances and staffing and things like that. So we feel like that's really important for a small office or a small practice today to keep in mind. They want to keep the control of their own practice instead of having a big corporation tell them what to do, unless they just want to show up and just collect a paycheck. There's a lot of physicians who want that. So I get that too.
Yeah, I think that's the tough spot, is that the money that those firms can bring in and private equity can throw at smaller practices seems very attractive. And I've watched cardiology practices and some other folks that we've talked to go through that similar thing. The biggest concern was not so much around the money, but then what happens and how the practice is run after. Private equity doesn't get into these games to deliver patient care.
Right.
They get in to make money. And so that's attractive. But then relatively shortly after the sale and closing and funding and all that, it's pretty quick
Mm-hmm.
that they start implementing changes. And so I can see that, and that doesn't allow a physician to really be a physician. They're worried about how to deliver that care, and then also continue to make a profit for the now, private equity owners. And they usually will take the majority share, right? So it makes it tough. But how you've come in and added all those elements is interesting. How do you determine, or really for the audience, if they have a private practice, and urology is one of those that you can. We still see quite a few people that can go out, maintain a private practice. There's a few other specialties. Some are staying, big and staying in hospitals or going to work for these bigger private equity groups. But how do you select what the best addition is? And it's not just, okay, well, that's just going to be an extra cost. It's a distraction. It's not a key line focus for us in a profit center that serves our patients better.
Mm-hmm. How do we select those items, or those people, or both?
Yeah, the things, the new additions that you bring to the practice.
Mm-hmm. Well, yeah, it has to make sense, obviously, financially, but that's not our motivation. The best example I have are the supplements. We have, I don't know, 40, 50 supplements that, we pick and choose. The providers are really involved with that. So that's where it's kind of different too. I ask the providers, which brand do you care for? Is it a clinical grade supplement? Is it something that patients can or can't get at Walmart? And is it $3 on the shelf? It's probably something that it's not very healthy for them. So we have all these factors, but we give the providers, whether it's our MDs or APPs, we give them the choice and get them really involved. And I think that helps with the health of the practice, because they feel involved. They feel like they make a difference, and they know that we're listening to them. And then when we add services, obviously for urology, it has to make sense. We have a really robust men's health line as well. So a lot of urology offices don't want to mess with that. They don't want to have their hormone patients and hormone optimization male patients coming in for their testosterone injections, because it's not a big moneymaker. But we look at it and, it's a tiny moneymaker and we're helping the patients. So it's not that, we're losing money on it, and the patients it's like a one-stop shop. And that's what I think is really important for smaller practices, to find a way to be more of a one-stop shop. You want to send out your referrals, obviously, to specialists, but you want to keep as much in-house as possible for the health of the practice, for sure.
Well, it seems more sensible from a patient perspective too. I don't have to keep going around and go to this physician, this place. So being able to get more from one location, that does sound very defensive, as Dr. Mystery had pointed out, doing some of those things. So we see a lot of residents and fellows that are coming from training and into practice. And a common theme that we will hear is that, we never get any kind of training around the business of medicine. And so therein lies the lack of confidence to, run a practice. They're great physicians. They've gotten great training. I don't really know how to run a practice. So what's the best way, if there's a way to sum that up, for them to get started?
Well, gosh, I can't talk a lot about how they can become entrepreneurs as much as Dr. Mystery. And I know he wants to do your podcast, so I'm sure he'll be happy to talk about all that too. But I can talk from what I think they should have in residency is a marketing 101 class for the physicians. I've met so many physicians in my career in Austin that have absolutely no people skills. And we've all met those physicians, right? They are never taught how to talk to other offices, admin staff, their own admin staff. I think there should be courses on not only marketing, but the business development, on how to react to situations within their practice. We've got a couple of really new doctors, and I've talked a little bit about this with them, and I can tell they're like, well, what do I do? And I'll tell them, we're going to go marketing. We're going to go meet these doctors. We're going to go talk to all these people outside in the community. And they're kind of wide-eyed, like, okay, let's do it. But they don't know what that means. And then I realized, oh, wait, I have to kind of take a step back and explain to them, okay, we're going to talk to a doctor's office. We're going to bring them lunch. You're going to interact with all of the people from the front desk to the back office. And I think it's such a simple idea that somewhere in residency, I feel like there's a place for it, but I just haven't seen it yet. So maybe I should start Donna Lee's marketing for physicians in residency. But I think that's really important to understand, because they just kind of clam up when they get in front of people.
Yeah, I think you're right. I think so many times we see physicians that are trained on the medicine side, and there's that other part of whether it be the people part or running the business. I was just meeting with someone at one of our campuses, and he's in charge of a lot of that. And they're actually putting together a leadership council for people that are considering private practice. And he said, we're literally having to go all the way back to teach about finance, about signing a rental agreement. Where do you buy machinery? What do rep relationships look like? How do you stay from a compliance? And so, Donna, what I think what you just described is something that is needed in the community, especially for the people that are listening to this podcast.
Right.
You know, they may be residents, the fellows starting out and trying to figure out, what does that look like? What does somebody like a Donna mean to our firm? When would they hire someone like you? At what phase, as they're considering that, when's a value add for someone like yourself to come in?
I think after they determine what they want to spend, obviously on marketing and business development, you know, whether it's 6, 8, 10%, they have to take that into consideration. I started as practice manager with this particular group. And I think what Dr. Mystery and I found as we went along together on that journey was that I couldn't handle all the marketing and business development and run the practice and pay the bills and hire staff and make sure the supervisors were happy. It's just, I think as a new physician trying to figure out how to start their business model, I think they come out of residency and they're like, you know what, I'll just pay somebody to do that. I'm going to have a manager who does that. Well, they have to keep in mind the manager is going to cost $80,000 or a CEO is going to cost $150,000 a year. The marketing person isn't even on their radar yet. Well, they had to hire 2 front desk people at $45,000 each per year. They've had to hire the LVN for $95,000 a year. Insurance is reimbursing so much less every year. I think that they're not even considering those things when they start, and then they think it's just going to be handled for them. But when they start in practice, they have to have a heavy marketing presence, especially if they're a small practice, because there's a bunch of little small practices that have already taken over the market share. And if they're brand new and they don't have a foothold or a plan or somebody to implement that plan, you know, they just might as well not even try.
Yeah.
So I think it's really important that they decide, you know, what size practice they want to join. And, you know, if they do want to be solo, I have a friend right now, he's a solo practitioner and he can't make it. He said, I have to sell my practice. I had a partner and she was not a good fit. So I had to let her go and I can't survive. I can't pay my rent. I can't pay my staff. And that's so sad because 10 years ago, 15 years ago, we were saying, oh, that guy's a doctor. I bet he's loaded. And now we're like, oh, that guy's a solo doctor. How's he paying his bills? And I'm not joking. That's exactly what's happening in the market now. So I think doctors really have to evaluate what steps they want to take, especially out of residency, because starting your own practice, unless you're like a wellness guy. I know a wellness guy, he came out as a PCP, he's a solo guy, but he started a really heavy presence in wellness and integrative functional medicine. So he's got a cash pay model along with his primary care physician model. So he's kind of covering the cost a lot better than somebody just coming out saying, I'm just going to accept insurance to pay for everything, because it won't.
You know, we've seen where the primary care market has created a model that is concierge, where they'll reduce their patient load and have an annual fee. Do you see the specialty of urology potentially going that direction, or other specialties?
I don't think so, because we're so procedure heavy. I know a lot of PCPs who went into the MD VIP model or something really similar. I've met a lot of APPs who have taken on clinics where they are doing that, a cash pay model. It makes a lot of sense, I think, as a primary care physician. As a specialist, I don't think so, because you still have to have those big procedures and you have to be credentialed at all the hospital systems and all the insurance plans have to pay and cover it. But we do have something similar within our practice for men's wellness. If a patient doesn't have insurance, you know, we can still help that patient. And we have a program, the one we call, we named the podcast after. So it's the Armor Men's Health program within our system. And if there's a patient in Texas who doesn't have insurance, you know, it's $150 a month. They have VIP access to their provider. So it's a similar program, but I think you really have to decide how much of that you want in your practice. And that only makes up a small percentage of our practice. But I don't think specialties can do that MD VIP kind of thing. But I think that it's really smart for a lot of PCPs to consider it, because there are a lot of patients out there that'll pay $100, $500, $1,000 a month to have 24-hour access to their physician by text or phone call and have that one-on-one time with their primary care physician.
Gosh, it's not even 24-hour. I think most of us would be happy sometimes to just get in within 2 weeks.
Right.
Sometimes to see our physician. So the backlog is increased, and it also allows them to see less people. So you get more personal time, the time that you get with them. So I think that's where the
Right.
success of that model is.
Yeah, those guys are only seeing 5 to 10 patients a day because they're spending 30 minutes to an hour with each patient. In a business model with insurance, like the majority of our practice, they have to see 16 patients to break even if they're lucky, and then 22 to 24 to make, a little bit more to cover some costs.
Yeah. I'm hearing numbers depending on the specialty, anywhere from 30 to 40 that is necessary to hit their numbers if they're on some sort of model where they're receiving RVUs and really want to try to make some extra money. They're having to hustle.
Yeah, that's 5 per patient if they're doing
Yeah.
notes and taking a breath between. It's not healthcare.
Right. Well, and it's contrary to really what they want to do. We see that and hear that consistently. Well, I have to go it this way and I have to run at this rate, and patient doesn't love it. The physician doesn't love it.
Right.
They're running too hard. And you mentioned a second ago the Armor Men's Health podcast. So this is something you did to help others, but tell us how you got into that and decided to do this and how that's going.
So the Armor Men's Health Show podcast is a radio show on local KLBJ in Central Texas on Saturdays at 3 p.m. And then we turn those segments into a podcast that we push out. So we've had, over 700 episodes now, over 150,000 downloads. We've had it for a while now, I think about 4 years. But if I have any advice for marketing, it's find a really unique niche like we did for our marketing. This takes up about 90% of our marketing budget because it's not cheap to put, a radio show on and then turn it into a podcast and pay me and pay my show notes person and pay the producer at the radio show versus paying me to produce it on the front end. So it's a lot of moving pieces, but we get to brand our message exactly how we want it to. So we talk about everything that's men's health related, and we even throw in some women's health as well because we treat a lot of women. But we did that. That decision was because we wanted to think of a really cool, unique way to market the practice and say whatever we wanted to say about it. And Dr. Mystery is an incredible educator, and you guys know him. He's just such an eloquent speaker. And in real life, he's the dirty one and I'm the clean one. But on the podcast, he has to be the clean one and I have to be the dirty one. So we formed this really strong relationship where we finish each other's sentences and we know what we're about to say and think. But it's a really fun marketing idea if you have two people who have that personality in your practice. But my advice there is to think of something that's super unique that people will remember, but still a way to really present your message about your practice in a way that's comfortable and makes sense for you.
Did you view that as starting the podcast as more of the community outreach portion of your description or the marketing to drive name flow back to the businesses?
In the beginning, the podcast was used for community outreach because the radio show of the same thing. So the Saturday radio show, we saw pretty immediate ROI. Like patients started hearing the show. Lots of people listened to KLBJ 99.7 FM and 590 AM. It's the only FM talk radio show in Central Texas. And it's a lot of, really awesome shows. And at the time, Rush Limbaugh was on. So there's a lot of conservative shows, but there's also like hippy dippy gardening guy. Like there's a really interesting group of people who listen to the show, and they would immediately start listening because we had a really prime spot on Sundays, and then we were moved to even a better spot on Saturdays. So we saw people coming in literally a week or two after we started the show. Like, I heard the radio show. I heard Dr. Mystery sounds so smart and engaging. And my urologist is kind of boring. And he didn't offer me supplements. And he didn't ask about my lifestyle management. And he didn't tell me I need to lose 20 pounds and that my testosterone would naturally raise if I did that, rather than me just getting injections for the rest of my life. So all these very unique messages started coming in. And I would say that the podcast, once those segments off the radio show were turned into the podcast, we started seeing benefit with people reaching out maybe a few months later. Like, we started getting lots of emails from people around the country because it started to take off. It didn't take off for probably about a year. Podcasts are tough when there's no marketing, especially with a really popular radio show on the front end to push it forward.
Well, you picked a good station. I'm familiar with that one, Heavy Men. Did you have to do a lot of research, or were you familiar with it?
My advice would be to research all the radio stations or TV stations. I had some offices approach us within the last couple of years, and they were guests on our show, and they were like, I wonder if this is a good fit for me. And my advice to them was to really research. Do you have the bandwidth to record every week? Do you have somebody that you're going to have trained, like I did, on how to record the show at the office? So Dr. Mystery's so busy that I have to catch him between patients sometimes. I'll set up all the radio station and podcast equipment in an exam room, and I sometimes pray that he'll walk by and give me 10 minutes to record a segment. And that's how it kind of got started, is that we couldn't rely on us to find the time. So it just kind of, what makes sense for the physician. But I had to do a lot of training in the beginning to try to make that happen. But my advice would be to, decide, do you like radio? Do you like podcasting? Do you think your audience is more TV based? I have a friend who's at an ophthalmology group, and he was really considering radio show and podcast, and he was asking me a ton of questions. And he went back to his partners, and they decided as a group, we're a really cute, young, up and coming ophthalmology group. Let's do TV. And I was like, sweet. If that makes sense for you, that's the best option. But it's also expensive. It's just, podcasting's not that expensive. You can do a podcast. You can record it on your own. You can push it out there. You can use like a platform like Buzzsprout, or I don't know what hosting site y'all use. I think it's Squadcast, right?
Squadcast. Mm-hmm.
Yeah, and then push it out. But when you go to TV, radio, I think that's an office that, if an office is just starting out, I don't think that's the best fit for them. I think they really need to maybe, start with a podcast for a year or two, get really comfortable with it. Then they can take that to a radio station and say, this is what we have, a really popular podcast. And can you give me a great deal on a weekly radio show? Or, how can I parlay this podcast into something on the news once a week? So that's, I guess, my consideration, my advice for consideration for new practices.
You stress a lot on marketing, which I would guess most physicians that are trying to go into private practice, they consider all the different elements. I need to have a front desk. I need to have a office manager. You check those boxes. I'm not sure that the marketing makes it to the top of the rung. So I hope that those that are listening take that away, that marketing at any level for any business, you're in business, that's the first thing. You've got to have that piece, right? And one of the other things you've pointed out is you need to be consistent. So you can send something out and it's not going to just answer things. You might get a couple of replies, but it's not going to answer your prayers so that, hey, we never have to do this again. It's got to be consistent and planned out, and having that a part of, it sounds like your entire budget, not your entire budget, but having that planned out needs to be part of how you plan for your practice.
For sure. And for smaller offices starting, I don't want to forget to say this, there are options where you don't have to have a full-time marketing person. You can hire a part-time marketing person or a group. Like there's one in Austin called Link Medical that's run by my friend Haley Carter, and she will work with 3 or 4 specialists that are completely different types of specialists. And she'll work 10 hours a week for you, 20 hours a week. You can just pay that kind of person, the physician liaison, a fee to do a marketing event for you. So there's so many options for new practices, especially smaller ones with really small or non-existent marketing budgets, where you can do these types of things. You can literally pay somebody who's super professional, engaging, and will represent your practice as if she's a full-time or he's a full-time employee, and get those business cards out to all the doctors in Austin, because you're the new, orthopedic knee replacement guy. Like you can't just expect the business to come to you. And I think physicians think out of residency, I'm so awesome that all these people are just going to refer to me.
They're just going to walk in the door, right? All I have to do is buy the furniture.
Yep.
And people will just start the parking lot. I'll probably need to get a valet. I'm going to be so busy starting off. Yeah.
Yeah. And Dr. Mystery, he's told me a million times when he started, it was just Dr. Mystery, his clinic person, Liz, and a front desk person. And he spent every minute of every hour that he wasn't seeing a patient in front of a primary care's office. He's buying cookies. He himself, not the marketing person because he couldn't afford one yet. He was visiting every office in Austin, and then he'd come back to the office and see a patient. Then he'd go back out and see more primary cares, and then he'd come back to the office and see a patient. So, that's a struggle. You either have to figure out if you want to dedicate your time and efforts like that as a new doctor, or if you want to pay somebody a small part-time wage to do it for you and focus on patient care, assuming it's coming in the door.
You think there's a consistency of what drives people like Dr. Mystery or even some of the successful private practitioners to go to that extra effort? Because it's not just being a physician. And like Chris said, coming out of training and into practice, and that's all I want to do. There's a lot of extra. So what drives a person to do that and put in the extra effort to have a private practice?
I think it's obviously how they're raised. It's a mindset. Dr. Mystery, though, has an MBH and an MBA. Like, he's very entrepreneurial. And I think a lot of physicians think they're entrepreneurial, but he's super unique in that respect, in that he's got the training and drive. I mean, I think he mentioned if he ever retires from medicine, his dream job would be consulting for big medical groups where he can go in and really evaluate what's going on with the practice and how to fix all of the little things and big things. But I think that it's just, a specific, if you're a shy guy, like we have two new doctors that are awesome, but I know that they haven't had time to think about business yet. So we're doing it for them, and hopefully they'll learn everything they can and decide in a few years if they want to stay with us or go start their own business model. But I think that it's just something you're born with. I mean, I hate to be cheesy, but a lot of doctors, that they're not all go-getters.
Personalities vary, but that it is definitely a key difference of I can be a great physician and maybe I'm not a people person. So I think that's probably something you need to address and confront as well. I want to be in private practice because of the control and the way I want to try to deliver healthcare to patients. But if I'm also not of the personality or the mindset or acumen, I don't have an MBA, I haven't exposed myself to those things. Find somebody that can help understand who you are and what you want. And you said a second ago, and I hope I don't get in trouble with Dr. Mystery, but you said a second ago about being a consultant. So, I think you have done that a little bit for some other firms where you come in and just kind of help them evaluate. They've done some things, they're off and running, but maybe they just haven't turned the corner. They're not as profitable. They're not as successful. Whether it's you, where can someone go to get pointed in the right direction to fix and tweak some of the things?
I think it's as easy as Googling medical liaison or, like I said, that group in Austin, Link Medical, is the one I'm thinking of. There's many of them, but that's one of the better ones. But they can certainly start there. I think word of mouth. Dr. Mystery recruited me from Victory Medical because he came to the practice. So a good example is if you're a physician, a specialist, you find a really good primary care group that you work really well with and kind of dig around and ask the questions. Dr. Mystery was in a position where he was kind of going between I'm getting too big for an office manager, but I'm not quite big enough for a CEO. So that was kind of where he was at when I met him. And he was asking me when I worked at Victory, what do you guys have in upper management? What do they pay? What do benefits look like? What does profit sharing look like? He had so many questions for me that I could give him an idea of what we were doing at that medical group. And he kind of modeled, some things here and there. He kind of took the a la carte pieces, and now we have exactly what we need. And in all the different management positions, we have so much more staff. We started with 20, 25 people when I started. Now we have about 60. So it might not sound huge, but that's, huge for us.
One of the things you've talked about marketing a lot, Donna, but what you just mentioned, having 60 people working for you, that's a whole different skill set, right? And I know that one of your roles and responsibilities, something that I've seen in person being at y'all's offices, is keeping the morale high, keeping the staff engaged in that culture. Can you share that? Like, we've talked about marketing, we've talked about getting things in, hiring people and keeping the employees on the same track and moving forward. You've talked about how busy the physician is seeing a client. How do you work with Dr. Mystery and the team to not leave the employees behind in such a fast-paced environment?
It's as easy as a calendar. I know it sounds kind of silly, but we have this really nice HR software that we use, and it tells us every day it may sound silly to doctors, but it tells us every day whose birthday it is, the anniversary, how many years the person's been with us. And I'll text our providers, hey, it's so-and-so, and with the providers who is at the location of the employee having the birthday or the anniversary. And I'll say, hey, so-and-so's anniversary is today, so-and-so's birthday is today. Dr. Mystery is incredible, and our other doctors are great about taking a minute to go give a hug and a thank you. And we really appreciate you. And then we support them with little gifts and gift cards. And those things are so important. And I think that the new physician coming into practice thinks that he or she might be above all of that or too busy for all of that. That will make the world of difference. If the employee sees the doctor took 2 minutes of their day to say happy birthday or thank you for being with me for 5 years or 2 years or 1 year, I think that goes so far. And I know that when I pass out goodies and make sure the physicians remember to say something, the employees, 90% of the time, I'll get a message or a hug or a thank you, or that really meant a lot to me. And I think that really helps. Those little tiny acts help with longevity for employees. But it's a constant reminder. You cannot forget anybody. I forgot somebody once and it was terrible. But you have to really stay on top of that. And you really have to get the physicians involved. As management, you have to get the physicians involved because you don't want that doctor who's so scary that they're not approachable.
There's other areas that you have gotten into personally. And we were actually, in fact, I started out the conversation with mentioning that you also do some stand-up comedy on the side, which was fantastic to watch you. And you are a very funny person. We really genuinely enjoyed it.
Oh,
But
thanks.
what we came for was regarding a charitable event, and it was regarding cancer.
Mhm.
So I'm really curious. I mean, I know it gave you an opportunity to stand up, do something fun, and Dr. Mystery was there, and which I think was really cool because clearly he's there to support you and be part of that. But how did you get tied into that? I think a lot of times there's opportunities, events that we tie into that motivate us that we're connected to. What was your connection with regarding cancer?
Well, I was having lunch with a friend, my son's friend. His mother and I were having lunch, and she said, "Oh, I'm part of this group called Regarding Cancer." That it was that easy, and I said, "Oh, that's cool." And she said, "We're thinking about putting a comedy show together next year." This is right at the end of COVID. She said, "When everything lightens up more, we want to put together a comedy show." And my son said that your son said that you are a comedian, so that's how that got started. It's an incredible little group, and if you have a patient who has unfortunately come down with cancer, they're a nonprofit group that pairs your patient as a physician, your patient with one of their patients who have a similar or the same type of cancer, and that person becomes a mentor. But that was just kind of an accident, honestly. That was the second year I've done that show, and then I hope to do the one next year and help them produce it. But you're finding your unique talents and adding them to your day-to-day things at work, make it a little more bearable when we deal with things that are so serious like prostate cancer and kidney cancer and bladder cancer with our patients. But yeah, thank you guys for supporting that group. It was awesome, and hopefully there's many more years of that nonprofit to be around.
It was very moving. You have this like huge swing of emotions. For 1 minute you're laughing your ass off, and then the next minute you're like really humbled by what people have gone through. So I thoroughly enjoyed it, but I see that there's an inline connection where now you maybe have a place where you're not just delivering news, but you're also maybe delivering a solution to deal with that news to your patients directly too. I mean, it's got to be a source for you to be able to share now.
Yeah, for sure. I think it's an amazing group that not a lot of people know about. So to bring that many physicians together, I was super excited. But I was the seventh funniest mom in America per Nick at Night. So
Nick at Night carries that scorecard. Use that. That's in fact, and that'll be the link in the show notes. Seventh funniest.
Dr. Mystery said, "When are you going to stop using that?" I said, "I can use it till I'm dead. Like that's my."
That's right.
It's like a doctor.
That's in perpetuity.
That's right. But that's like a doctor saying, "I was the first to use this particular robot in Washington," or something. I mean, it's going to be my thing forever. So.
Right. We don't even use that machine anymore. Yeah, it doesn't matter.
It doesn't matter.
Was the first.
I was the first.
How did you get into comedy? What was that? What was that like?
It was that I was a stay-home mom. I was drug rep, like I said before. Then I became a stay-home mom for a while, and I went through a really, really awful bout of postpartum depression that I didn't expect because I loved being pregnant. It was the best, coolest thing in the world. I felt amazing for the 9 months I was pregnant, and then when my child appeared, all of a sudden I came down with the worst postpartum depression, and it was so crippling and awful. And it was that point in life where I think we've all been there. You wake up and you go, "I'm going to do what I want to do in this life, or I'm not." And so one of my big dreams was to be a stand-up comedian. So I started going to Cap City Comedy and doing open mic nights. And I had a very unsupportive husband at the time. And he inspired a lot of jokes because he was, he's real country and did not like what I was doing. And he's like, "Where are you going now, mama?" I mean, just things like that. And I'm like, "I'm going to do comedy by myself in a nightclub." It was not a good fit. But then I ended up submitting my tape when we had tapes back then to Nick at Night because I saw on TV they were having a contest for funny comedian moms. And 6 months into my stand-up attempt at Cap City Comedy and the open mic nights, I hadn't even gotten a real gig yet. I sent in my videotape of me on stage doing an open mic night. That was probably hideous and awful, embarrassing. But Nick at Night called me right after they got my tape, and they said, we have 20 spots and we filled the 20 spots for the semifinals, but we're going to open one more spot for you. And I was like, because I'm cute and I have big boobs. Like, I had no idea what that meant. Why are you doing that? Because I had no experience.
Yeah, because it's Nick at Night. Of course, that makes sense.
And it was true.
That's what they're looking for.
I found out later it was in fact true because I had no experience. But then I ended up going to LA and did the contest, and then I made it to the top 10 finals, and then I made it to the reality show, TV show thing. And you all saw part of that bit at the show. But it was a really humbling and awful and exciting and amazing experience. And I love that I have that background, and now I get to do this podcast and I get to be a guest on shows like this. So it's been fun.
I think doing something like that where you just stand up in front of essentially all of your fear and all of your dreams at the same time is empowering in a way that the normal day-to-day stuff of putting together, going and walking into doctors' offices, introducing yourself. Sometimes that in itself is very difficult to do. I don't want to go do that part of the marketing. I don't want to walk in somebody's office and introduce myself. Believe it or not, that feels embarrassing to people. So that's harder. So if you just overdo it and put yourself way out there, then the rest of that makes it really easy. I think it's great that you're still out there creating different experiences for yourself. And then it still, again, kind of ties back into the practice and keeps things fun. We talked about marketing and some of the other headwinds and declining insurance reimbursements. Where does it go from here? What do you see besides what you've already addressed coming up for people that are thinking about going into private practice or already out there?
That's a big question. I don't know. I commend any doctors coming out of residency who wants to make the attempt. I mean, it's just so hard. I feel like I've been really discouraging this whole time, but I just wish people
And don't do it.
join private equity. I said it was the devil. I was kidding. No.
It's the good one. It's the good devil.
It just depends, I suppose, on the physician. I mean, I know a lot of physicians that didn't go with it. We tried to hire a lot of physicians, several, and they went with a bigger group, or they went with a different city, or they went, with just a different model. And that's hard. And it hits our ego like, wow, what's wrong with that? It's like dating, right? You're like, well, I thought it was great on our first date. What,
I'm pretty too.
we don't get a second date. Like, what is that about? But then when you realize it's not for everyone, and you have to find the right fit. So if you're, coming out of residency, spend hours and lots of plane trips and find the right fit. We've interviewed people. Thank God for Zoom, because we didn't have to fly so many people in, but we're still interviewing people by Zoom for, want to hire more doctors in the near future. So I don't know how to answer that question other than, just absolutely do all of the uncomfortable things that you don't want to do to figure it out. So don't pick the first group that says, here's $500,000 a year. We're going to pay you a lot and we're going to own you. So, decide.
Yeah, it's the fine print that binds us,
Yeah,
right?
and maybe that's what people want. They want to be owned and they don't want to make decisions. And that's probably why we lost some candidates that we thought would be a good fit. But if you're the kind of physician that's coming out, be aware of what you're walking into and ask all the questions. And I would ask, this is kind of more than what you've asked, but I would ask for their financials. Like, we're really transparent about it. Here are all our financials. This is what it looked like last year. This is how we split the cost. This is what our front desk person costs. This is what the medical assistant costs for you. This is what, this is what the pen and the paper and the ink costs are. And we pay this much for bills. Ask those questions. And then that'll also help the physician decide if they really want to take on all of that, as a small practice type of provider, or if they don't want to deal with it. They're like, nope, I want to be in a big practice because I don't have to worry about any of that crap.
I think it's pretty interesting that you would share financials up front. Certainly it's quid pro quo in that situation. Like,
the transparency. The transparency during the recruiting process. That's an interesting model, especially that early on. Maybe we see that later.
Yeah.
And it's like you go through the quote unquote, as you were talking about, the dating recruitment process. And then towards the end is when a group says, by the way, here's our financial standing. Once there's more of a little bit of a soft commitment. And I think what Paul's mentioned is y'all seem to do that earlier on, right? Is that appropriate? Is that correct?
It's speed dating. So after we decide, okay, this person's a possible fit, maybe not the best fit, we don't know that yet, but yeah, not right off, like, hi, my name's Donna, here's our financials. But at least Okay, I typically interview providers first up front, and then if I feel like they're a good fit, then I bring in Dr. Mystery and our practice manager Liz, and we have a discussion, and then we talk to the provider, and at that point, if we all agree it's a good fit, then that's where we're like, okay, here's all of our private pieces and parts. Do you want to take a look or not? So that's, I think, give it a minute, but dating and speed dating, it's all relative, right?
How much of that gets disseminated down from not just the providers, but to some of the other people in the practice?
We are very transparent with the upper management team too. So they see all of the, every month we put out. So I know that I've talked to a lot of APPs that joined us, and they're like, I've never been part of a practice where I got to see my peers' numbers, because we have a really heavy model on paying people. It's an eat what you kill model with us. You get for our APPs, you get a salary up front, which is something the physician might want to consider if they're paying APPs. Do I pay them an annual rate, a flat rate, or do I give them incentives and bonuses? Like, all of that's super confusing to a new doctor when they get to the point that they need an APP. But the advanced practice practitioners, they're very open and aware of, and it's kind of setting up a little bit of a competition every month. So they're like, oh, the nurse practitioner they hired last month, she beat me by $10,000 last month. What did she do differently? And then they have chats every week, and it's really important for our providers to meet once or twice a week. So another thing I wanted to impress upon new doctors, the patient physician, is to be patient with meetings. You have to have the meetings. I think the doctors think, they're too busy to have the meetings, but you have to carve out that time to meet with your support staff and your APPs and make sure everybody's on the same page and everybody's considering the growth of the practice every day. Not meetings every day, but considering it every day and having meetings maybe every week or monthly.
And what's a good frequency for something like that? Is it monthly? Is it weekly or bi-weekly? How often do you do something like that, or even do you do a biannual or a annual, like, bigger kind of retreat as a group?
Yeah, as a group, the whole practice, we try to do a big team building event once or twice a year. Our MDs who are partners, most of them are partners to the practice, but all the MDs meet at least once a month. And then we have the new MDs who just joined us meeting with our APPs who meet with Dr. Mystery. So there's a weekly meeting for all of the APPs and the new MDs with Dr. Mystery, where they can talk about cases and talk with the pelvic floor physical therapist and talk to, the in-house sleep coordinator. They can all kind of talk about what's going on for their week. But if we didn't do that weekly with them, it would be a nightmare trying to get that condensed into a meeting once a month, because then that's a 4 to 6 hour meeting monthly, when we can just dedicate that time once a week for them.
Hey, Donna, I want to camp here real quick, because I think one of the things you had said, whether it be through the podcast or the radio show and being in the community, of keeping people's calendars full, right? It's getting the meetings, getting the name out there. When you have the transparency in a competitive type of environment like that, do you ever get pushback on, well, this person got more meetings, or is it a round robin? How would you handle distribution of new patients or something of that nature? Or once they get to a certain point, is it referral based and they're more responsible for keeping their calendars full?
The providers, you mean, keeping their calendar full?
Yes, the providers. Yeah.
We are blessed in Austin, Texas, that there are so many people moving here that we just have full calendars. Like, the new doctors right off the bat were full.
Wow.
Their clinics were full by 80% the first couple of weeks. And I looked at their schedules yesterday. They've been with us 2 months and they're 95% full already. So we really have to be careful, because their meeting times are now being taken by patient slots, because our staff means well, but they see, oh, that doctor doesn't have a bunch of patients in the morning from 8 to 9. They must be drinking coffee. I'm going to open up that schedule. And even though we've told the staff not to do that, they mean well, right? They're like, oh, I see a blank spot. So they're just filling. So we don't have a problem with that. And I don't think most specialists would in Austin right now in 2023. I don't know how that's going to look in a few years, but yeah, it's super important to make sure that time is uninterrupted meeting time with the staff and the support team, for sure. Did that answer your question, or did I kind of?
Absolutely. Yeah, I didn't phrase it correct. I didn't phrase it well, and you, of course, answered it well. Thanks.
Oh, now we're nice to your guests. We are not.
We Mystery started out as a private practitioner, just him, and now how many MDs do you have on? And you said 60 employees total?
Yeah, we have about 58, 60 employees. We have 6 urologists, surgeons. We have 1 interventional radiologist, which is super rare and unique for urology. Most urologists would have to refer out. Dr. Smith is our prostate artery embolization interventional radiologist in-house, and he does a bunch of other embolizations. But then we have 5 APPs, so nurse practitioners and PAs. We have 2 pelvic floor physical therapists. We have a sleep coordinator on site, sex therapy on site, and what am I forgetting? I think that's good. Oh, we have a health coach. I forgot. We always have a health coach, and Dr. Mystery was the first to have all of these back in 2007 when he started his practice. No urology office in Austin had pelvic floor physical therapy, and he did. So he was, on the forefront of those. And having a health coach was something pretty new. But new specialists coming out of residency when, they have to sadly diagnose a patient with cancer or a life-changing, altering diagnosis, the very first thing they ask is, what do I change? What do I do? What do I eat? How do I lose 20 pounds before surgery, like you said? So we thought it would just be so much more beneficial. It's not a big moneymaker for the clinic, but it's a big patient saver for the clinic, if you will. So things like that, the doctors need to really consider when they're coming out of residency. Do I just want just me, or do I need all of the support? It makes sense for us because other specialists have to send the patient out for pelvic floor physical therapy. They have to send the patient out to a wellness provider to figure out what's the best diet plan for that patient to lose 20 pounds before their big prostatectomy or, their big surgery that they have. Where's the sex therapy person in Austin? Like all of those things, we've just brought it in-house, whether it's full-time or part-time, it's totally available to our patients. And that brings in the patients. And Dr. Mystery talks a lot about the 7 touches to a patient. You want to reach that patient 7 times and they'll become your patient for a really, really long time, whether it's just...
Are you trying to make Kevin Bacon your patient or the 17? That's a different...
I think I'm related to Kevin Bacon because my grandmother, her maiden name is Bacon, and she was related to Sir Francis Bacon, and I know he was as well. So I'm pretty sure you're looking at a Bacon relative right here.
All right. So Kevin, if you're out there, reach out to Donna and just get the family lineage cleaned up.
Cousin.
Was there a place where going from 1 to 2 to 2 to 3, because sometimes adding the first one is very difficult. Then, maybe it's even more when you have the third. Have you turned the corner? Has it gotten easier? Has it gotten harder? More? I mean, things continue to evolve. If you're looking to grow a practice like you all have,
I think it's maybe a little easier for primary care physicians or dermatologists. They seem to be more available. It is almost impossible for me to find a urologist. I've had to reach out to recruiters. Before, 10 years ago when I was at Victory Medical, I could find providers on my own. I hardly ever needed a recruiter. I could find MDs. I could find nurse practitioners, PAs, just posting ads and reaching out to different types of groups. But now it is impossible because there's so few specialists. If you try to find a neurologist to join your group, a urologist, an endocrinologist, those very specific specialties, they're just super hard. And you would think it'd be easier living in Austin. It's still hard. I still have recruiters helping me because I can't find the doctors. So, consider geographic desirability for sure, but it's tough in 2023. So I don't know what the advice is there, except to know that it's a long, painful process, but you'll eventually date again. You'll find that person you want to date.
Well, if people haven't caught the underlying theme and want to go in private practice, it sounds like y'all are hiring. So, contact Donna, right? Exactly. We're not going to make this dating hard. Contact Donna. So
I'm third base ready.
That's right.
Transparency.
That's right.
It's a key word.
We'll have all the financials at the end of the show. As we wrap up, the name of the show is The Patient Physician, which we think means different things to different people. Tell us what you think it means to you and your experience in working in private practice, and for those listening.
I saw your words and followed your directions, and I even came up with a little something. But I love the title, The Patient Physician, because I work with so many inpatient physicians. But I wrote a little blurb about, I think the patient physician means that the physician needs to remember to be patient with not only the patients, but with the staff, the support team. I think it makes more sense, like I said, to schedule those meetings and to really consider all of the people helping you with your practice, and be super patient with those people. Not, I think it's pretty obvious that you need to be patient with your actual patients, but I don't think there's enough people telling the doctors to be patient with the people who are supporting your practice, your livelihood. I think that a lot of doctors too, if they're kind of too, involved with being a doctor and not remembering that there's a support staff, I think they're unapproachable. And I think that the staff at that point kind of takes a step back and they're not as involved. But I think the doctors really need to remember the staff, the support staff really wants the best for not only themselves because they're getting a paycheck, but they do want the best for the practice. I'd say 90% of people are like that, right? There's those bad seeds that you might get that you have to detach from, but be patient with those people that show up every day, that drop their kids off at school, that came to spend more time with you and your practice than they're spending with their own family. Be kind, be giving, spend a little extra money on every one of your people. And I think that's the takeaway message I wanted to leave.
I think it's amazing. I want to thank you. It's been great to see you and catch up. I hope that those listening have gathered some key details and certainly add in that key piece of marketing, but where you left off, taking care of the people around you is going to be so vital.
Donna, thanks so much. I want to just say thanks for the invitation for the event around cancer and bringing laughter into a very serious world that we're all in. And we all have family events that are going on, and just let you know that we all appreciate what you're doing in the medical arena, but also just bringing awareness and that connectivity to our community. We appreciate that as well.
Oh, well, thank you guys. Thank you for having me. I'm really honored that I was a part of this, and you guys are doing great work as always, and you're so kind and fun. So keep in touch. Thank you.
Thank you.
Thanks, Donna.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects Podcast Network. Please email questions or show ideas to info@physiciansrs.com.